Ladies and gentlemen, I'm Cangitaa Arumugam, Medical Officer from Emergency and Trauma Department, Hospital Sultan Abdul Halim, Sungai Petani, Kedah. My topic case study would be I cannot, a forgotten disease. I was actually expecting they wouldn't mention the disease at the beginning. Okay. So first, I would like to give a small introduction to my topic, which actually touches on the global issues. So tens and thousands of Rohingya have been fleeing from Myanmar in the past years. Many of them been using the sea, especially in the spring of 2015, trying to reach basically Malaysia, India, and Thailand. The latest surge of refugees was prompted by the long building crisis, the discriminatory policies of the Myanmar government, causing the Rohingya to flee Myanmar since the late 1975. Most of them turned to the smugglers for transport out. They choose to pay to escape the persecution. The refugee crisis has fled over the past few months, especially end of 2014 and early 2015, following the crackdown on the human following due to the human trafficking, the crackdown of the human trafficking by the Thai authorities. There was recorded about more than 137,000 of So there was recorded about 137,000 of Rohingya registered in Malaysia as of September 2014 by the United Nations. Yes, this will take some time.
Very sorry for the delay. There's a technical error in the computer over there. It's rectifying it now.
Okay, sorry for that. So as I was telling earlier, most of them been using the sea, so they are transferred to Malaysia, Thailand, or Indonesia in a crowded situation, filling up boats. So in August 2014, we actually received a 70-year-old Rohingya man. He was actually brought in by police under human trafficking case. Presented with complaint of severe lethargy, weakness, and pain over bilateral lower limbs. History that we got from the police that he was found locked in a small room with 60 others. So during the days, they spend their time sitting in a confined space. At night, they basically sleep upright or in fetal position. They were only given one piece of bread per week. On physical examination, he was a young man with low body weight, lethargic, and dehydrated. His blood pressure was 99/53, heart rate of 102 beats per minute, oxygen saturation of 98% on room air, and he was normothermic. Our initial impression was dehydration, so we hydrated the patient, observed him in observation for 16 hours, and he was discharged from observation bay. However, 10 days later, he visited us again. This time, he complained of worsening pain over bilateral lower limb, especially over the calf region. There was increasing in muscle weakness. He was unable to rise from sitting position, unable to ambulate by himself. There was also a reflexia. His examination, lungs was clear, CVS door rhythm normal, abdomen soft, non-tender. So, at this moment, we had a few differential we talked about a few differential. The problem that we had in this patient, especially the problems that we will have in refugees, immigrants, is difficulties in cross-cultural communication, difference in health practice belief, and also limited cultural awareness. Our problem that we had with this patient was communication. During the first visit to emergency department, we were not able to get full histories due to the communication. Second visit, they had the translator with the police. So with the translator around, we were able to get detailed history, and also we were able to perform full clinical examination. True, we did think patient was malingering in the beginning, but we also thought of other diseases. So the first we thought is GBS. There was progressive weakness, presence of reflexia, and also pain. But there was no any cranial nerve involvement, no autonomic dysfunction. And history with the translation, there was no any infection 3 weeks prior to that. Hyperkalemic paralysis, presence of muscle weakness, a reflexia. But this patient's weakness was persistent. There was no any episodic muscle weakness. And in the beginning, we did correct the patient with potassium supplement. No improvement of muscle weakness. Toxic-induced neuropathy also came to our thought because they were detained in a small room. Motor dysfunction, but there was no any other signs that lead us to toxic-induced neuropathy. Myasthenia gravis was another thing due to the muscle weakness, but no improvement of the weakness with rest. There was no any ocular involvement. It was not like ocular, facial, and towards the lower limbs. It was more of lower limbs. And as the diagnosis was already told in the beginning, we thought about BeriBeri. Basically, what made us think about BeriBeri, thanks to the technology, during that moment, our ED WhatsApp group was somehow discussing about BeriBeri. And there was a newspaper cutting from UNHCR in June 2014 that stated that in Kuala Lumpur, there was 120 Rohingyas being identified by UNHCR KL with BeriBeri, and symptoms improved with supplement of thiamine. So we try to relate our patient to dry BeriBeri. Presence of muscular weakness, abnormal gait, and later unable to walk. There was atrophy of bilateral lower limb muscles, painful calf muscle, absence of reflex, especially over the ankle and knee reflex, and there was significant history of inadequate food. There was a few studies that have been done basically in refugees, detainees, and immigrants that actually showed prevalence of BeriBeri. This basically occurs in places where they depend on outside source of food, meaning provided by the center where they are detained. Actually, 2 researches were done in Malaysia. One in a drug rehabilitation center and another one among refugees that came to Malaysia. So BeriBeri basically means I cannot in Sinhalese. It's basically what the sufferers says as their disease progresses. They cannot walk. It is caused by vitamin B1 deficiency, thiamine. BeriBeri has puzzled the medical experts for years. Initially, the doctors actually thought BeriBeri is caused by something that is in the food. Not till the late 1800 did the scientists realize that it's caused by the rice bran, which is the covering that covers the rice that is being removed to produce polished rice, contains something that can prevent the disease. So initially in 1800s to 1900s, the disease was quite prevalent among Asians, as rice is the major source of food, which still is. Ekman, the man over the right, he was the one who discovered BeriBeri. He noted that chickens fed with refined white rice develop acute head retraction, which can be reversed by feeding them with brown rice. So that was when thiamine was first discovered in 1934, to be exact. Today, because of food fortification and also general improvement of living conditions worldwide, BeriBeri became an extremely uncommon disease that is forgotten. BeriBeri has to be... Recently, we have to look back into BeriBeri as increasing number of refugee population as well as other causes which can be alcoholic disease and also total parenteral nutrition without thiamine. There's a few classifications of BeriBeri. Peripheral neuropathy, which is also called dry BeriBeri, cardiac BeriBeri or wet BeriBeri, BeriBeri with gastrointestinal involvement and also eye involvement. Others are infantile thiamine deficiency also present. Signs and symptoms, as I mentioned, presence in our patient: bilateral lower limb great weakness, painful calf muscle, especially the calf muscle, numbness over the feet. In later stages, they may develop foot drop or wrist drop. Another type, which also common presentation according from the researchers that we saw, there is also common presentation of wet BeriBeri or cardiac BeriBeri. This picture would be different. This one, the patients will come with more of respiratory distress. They'll be having difficulties in breathing, swelling over the lower limbs, they'll be edematous, and there might be pleural effusion with heart failure. Outbreak of BeriBeri has been reported in prisons and among refugees. These populations are more vulnerable because there is micronutrient deficiency. WHO's standard food supplement actually targets 2,100 kilocalories per person per day, where the micronutrient needs receive less attention. This is basically to the detainees and refugees that receive supply from the government or centers. So there is biochemical detection for thiamine deficiency, but mainly our diagnoses have to be based from the clinical presentation of the patient and dietary history. Okay, we can also do blood thiamine test, ETKA and TPPE, but all this is time-consuming and cost-consuming. So this might delay our diagnosis and treatment. So trial of thiamine supplement is actually a better option for improvement of the patient and from causing further fatal consequences. So recommended daily allowance for thiamine, I'll just touch on the adult. WHO actually suggested on 0.4 mg per 1000 kilocalorie. So it increases as the calorie increase, the intake should be more. So the treatment, the general approach should be airway. As I said, wet BeriBeri can come with respiratory distress. So we have to, as usual, always secure the airway breathing. Circulation basically for dry BeriBeri, where the patient may present dehydrated. So this patient, we can start on hydration. There was a research also saying regarding cardiac BeriBeri, the rules of furosemide in cardiac BeriBeri. This actually, they are elemental, so we will think of furosemide. This actually worsens the condition as furosemide will wash out the thiamine more. The specific approach actually for critical patients is basically management with IM or IV thiamine, 100 mg usually, followed by 10 mg orally for 3 months. Prophylaxis doses can be given to other detainees, 1 mg daily. For our patient, we actually started on IV parenteroid for 3 days and also thiamine supplement 10 mg daily. He was kept in our old hospital before discharge for about 14 days. We didn't discharge him, he was sent back to Myanmar. So by that 14 days, there was improvement in his weakness. He was able to get up by himself, raise from sitting position by himself, and was able to ambulate, but he was still needing some assistance. But there was improvement in muscle weakness. So my take-home message would be, BeriBeri is basically a textbook disease where doctors have never usually seen the cases. We were lucky that we are at the north, so we actually saw this case. It's not something of civilized world. With recent increasing number of refugee influx, we should be having high index of suspicion of this disease. When involving any patient that has been detained for a period of time, immigrants, refugees, prisoners, we should keep this in our mind. Early administration of thiamine will improve the outcome of the disease. So basically, when there is a clinical suggestion of dry BeriBeri with history of food insufficiency, we should also think of BeriBeri. With this, before I end, I would just like to touch a bit on this recent oral acid children that was missing about 48 days ago, 1 month ago, more than 1 month ago. So recently, there were 7 children who went missing. They found 2 children 2 days ago. After 46 days, they were trapped in the jungle. So news just mentions that they were very lethargic and malnourished. Could not get further information from them because they were tired, lethargic. So I think this case, they should consider dry BeriBeri also with the history of high suspicion, no food intake. They were basically living off leaves, and also their presentation, weakness, and also unable to ambulate due to weakness. This is my reference, and thank you.
Dr. Cangitaa, for the expert.
Thank you for the presentation. I think when you're dealing with refugees, you're dealing with not just BeriBeri, but a lot of other things as well. On my side, I've never actually treated the refugees, but how many are y'all seeing a day?
Actually, during that period, we got 4 patients. They presented with similar cases. 60 was trapped, but we received 4 patients with similar presentation. I took one of him.
So these were the patients that were basically kept
in a small closed room for more than 60 days. 60 people kept in a small room for days, which we were not sure about the days. And they were the ones that came by boat, so they were also in a confined place there.
Which a lot of other things to think about as well. BeriBeri approach just one component, because I saw your earlier slide, they were given just one piece of break for 1 week, right?
1 week, yeah.
So giving the parental right was probably the best way to go. Yeah. Thank you.
Thank you.
I think you were probably joking when you said you were considering malingering. Because I hope you were. I think I always wanted to invent a pen that when you wrote certain diagnoses, it gave you a little shot to remind yourself not to diagnose that patient. Malingering is probably one of those diagnoses you can just throw away. But I just want to echo the comments of my colleague. A special population like this, refugee population, someone who's obviously extremely malnourished, who's come from a situation like this, falls into a special category where it could be any number of severe pathological conditions, one of which should be any number of conditions associated with malnourishment. We don't see a lot of refugee populations where I work in Baltimore, but we do in other parts of the United States and obviously in other parts of the world. And there is significant study paid to health maintenance, health recovery of refugee populations. So it's something that as emergency physicians, if you're working in this part of the world, or even if you're not, it's good to read it, understand it, and to have that suspicion when a patient from this uncommon but clinically significant population presents.
Okay, I think you must remember this is a very, very uncommon disease, but we have the berat disease a lot. Obesity, because berat. Okay, with that, thank you. We thank all the presenters and the expert panelists. And I'll pass to Cangitaa.
Okay, thank you very much, Dr. Lutfi, our chairperson.